نسمع ماسيج بانخ، هو من بولندا وهو هيكلمنا على RNA based therapy in dyslipidemia management. الريكوردد برضو، احنا عندنا 2 recorded presentation.
Hello, my name is Maciej Banach. I'm professor of preventive cardiology and lipidology from the Medical University of Lodz and the president of the International Lipid Expert Panel. It's my great pleasure to be a part of this great and very important meeting of the Egyptian Association of Vascular Biology and Atherosclerosis and ILEP on this cardio risk. During this cardio risk meeting, I would like to say a few words about the RNA-based therapy in dyslipidemia management. Obviously, I will focus mainly on inclisiran because there is no time enough in order to discuss, for example, pasiran and other SE small interference RNA drugs that are in the future perspective. This is my potential conflict of interest. We know it very well. They take into account the data that was presented in ESC at the ESC Congress that we are not effective in the lipid lowering management. Please have a look at the data from the reality trial, in which almost 2 million patients were included. The data was gathered by 2019, and as you can see, only 3% of patients were on the LDL cholesterol target below 1.4 millimole per liter, and less than 15% below old target for LDL cholesterol based on the 2016 guidelines below 70, so 1 per 8 millimole per liter. If we look at the different atherosclerotic cardiovascular groups, you can see that the largest unmet need are for those patients with peripheral arterial disease. So those patients that are indeed very rarely diagnosed in cardiological departments, they are mainly transferred from in the last many years to Department of Interventional Surgery, as well as those patients with PI and stroke. So that is why we need to focus not only on those patients with MI, but also on other atherosclerotic and vascular beds. So when atherosclerosis may appear and may be linked with the morbidity and mortality. What is more, if you look at the data from the Santorini trial, we know it very well that which is a kind of continuation of the Da Vinci study. We know it very well, and it was performed in 2020, 2021, that it was only a small improvement in the number of patients being on the target below 1.4 millimole per liter, because it was improvement from 18 to 20.7. And obviously the largest unmet need was obviously again associated that most of those patients were treated with the unsuitable doses of statin only, mostly with the low to moderate statin therapy, and it was very few percent of patients treated with the combination therapy of statin and ezetimibe and with PCSK9 inhibitors. What is the reason of our ineffectiveness as well? We should point it out, and we should focus on. Please have a look at the data from the GOLD registry. In the GOLD registry was started in 2018 and it was followed by 2 years after the new targets for very high risk patients of LDL cholesterol was introduced. It was below 1.8 millimole per liter. And then the authors noticed after 2 years that only 17% of patients were intensified with lipid lowering therapy. And if we look at these cohort of patients treated with PCSK9 inhibitors, please have a look that there was no intensification of high intensity statin therapy. There was no increase of the patients treated with ezetimibe. And this was the main reason, in fact, that the final improvement, so the number of patients being on the LDL cholesterol goal wasn't as significant as it was expected based on these new guidelines. So that is why it is so critically important to focus on each step of the lipid lowering therapy, because it is so important, because based on this we might have indeed and may have patients on the LDL cholesterol target. And then the largest mistake is usually associated with the fact that when we start ezetimibe therapy, we usually reduce statin dose. When we add PCSK9 inhibitors, we usually discontinue ezetimibe, and this is the largest mistake we should fight against. This was also confirmed in our study that it is going to be published soon in Polish Journal of Cardiology. It was based on the data from the comprehensive coordinated program of patients after acute coronary syndrome. As you can see, after 12 months of this program, there was a significant decrease of the number of patients on high intensity statin therapy. There was obviously small increase of the number of patients on the combination therapy, but in the end, we've noticed that the escalation of the lipid lowering therapy was observed in almost 24% of patients and intensification in only 9%. That is why we need effective drugs. And obviously, since in last several years, we have PCSK9 inhibitors with beautiful trials and beautiful data showing its significant effectiveness. But we have also another drug, which is small interference RNA, which is inclisiran. It is quite unique mechanism of action because it is smaller. Inclisiran, in fact, binds to the asialoglycoprotein receptors, which are only available on the hepatocyte surface. That is why it is very much dedicated only for those cells. And then in the hepatocytes, as you can see, it is binded to the risk protein, and this process is based on this, it is a kind of degradation, catalytic degradation of messenger RNA for PCSK9 protein, and that is why it is a very effective process. So from one hand, take into account this asialoglycoprotein receptor, take into account the risk protein, take into account the circle process, it is very effective. On the other hand, according to the fact that it is only take place in the hepatocytes, it's also very safe effect. Please have a look at the results from the Orion 9, Orion 11 trials, in which Orion 9, it was in patients with heterozygous FH, and Orion 10 in patients with atherosclerotic cardiovascular disease, and Orion 11 in all of those patients. So not only in patients with atherosclerotic cardiovascular disease, but also in patients with heterozygous FH, also in patients in primary prevention, because these were patients also with the risk equivalence. Please have a look that it was a significant decrease of the LDL cholesterol up to day 540 from 44% as a difference between group difference in patients with heterozygous FH to almost 50% in those with atherosclerotic cardiovascular disease and atherosclerotic cardiovascular disease equivalents, and over 50% in those patients with atherosclerotic cardiovascular disease. If we look at the absolute reduction of the LDL cholesterol, it was between 51 to almost 70 milligrams per deciliter. So it is a very effective treatment. But let's have a look also at the number of patients being on the goal based on this therapy. And please have a look at if we look at the old goal, so the 2016 guidelines, 1.8 millimole per liter. In this group of patients with heterozygous FH, inclisiran was associated with the additional 40% of patients being on the goal. In those with atherosclerotic cardiovascular events, and in the Orion 11, it was even over 70% of patients being on the goal. But if we look at the number of patients below 1.3, it was a little bit different point that it was measured in those studies, because it was they were designed before the 2019 guidelines. Please have a look that only in heterozygous FH patients, these were only 19% of those patients being on the goal. So that is why, again, it is so important to focus on each step of the therapy, because if we fail, then it will be only a few percent of patients additionally on the goal, despite such a effective, such a innovative therapies. And much better results were for atherosclerotic cardiovascular disease, and those patients included in the Orion 11, because it was between 50 to over 60% of patients being on this goal, 1.3 millimole per liter. What is important? It is a little bit similar to PCSK9 inhibitors, but even it is a much larger effect, because 99% of those patients achieved LDL reduction at day 510. So that is why the response rate for inclisiran is very, very high, almost 100%. So there is no, in comparison, for example, to statin, for which we might observe even in 5 to 7% non-responders, in about 15% of 20, even 20% of low to moderate responders to statin therapy. For inclisiran, we have now 100 patients that responds to LDL cholesterol reduction. What about the safety? It is, I don't want to focus on it much, because we know it very well that it is a very safe, as I've mentioned at the very beginning, therapy, which is only associated with the injection site reaction, and in most of those cases, it is only mild to moderate injection site reaction, so that it shouldn't be any problem in order to use this drug safely. What is the difference in comparison to PCSK9 inhibitors? One of them is obviously associated with the way of administration, because twice a year. Another one is associated with the fact that this treatment is effective in a severe chronic kidney disease patient with end-stage renal disease with EGFR between 15 to 29. So this is a great challenge for all the cardiologists to treat those patients, taking into account the lipid disorders. So we have finally the drug that is safe and effective in those patients. What about the guidelines? First, in September 2021, in the Polish guidelines, we, based on the data from the fast free trials, we said for the first time that inclisiran should be indicated in patients with atherosclerotic cardiovascular disease or with FH, and those that being at the maximal tolerated dose of statin are over the target. It should be also indicated for patients with statin intolerance. But obviously, we do not have data. It is something that we need to emphasize. We do not have data for statin intolerant patients, but we obviously extended the fact that this is a very effective and safe treatment for patients with the lipid disorders that obviously we might also consider in patients with primary prevention, because atherosclerotic cardiovascular disease risk equivalent patients were for the first time, and this is the difference in comparison to PCSK9 inhibitors, were included in Orion program and in Victorian program. In fact, what is more, if you look at our recommendation based on the paper published in European Heart Journal, please have a look that for the first time we said, as a part of this pathway, that in those patients with the upfront combination therapy of statin and ezetimibe, if we are not effective, we should consider PCSK9 targeted therapy. So obviously included inclisiran or bempedoic acid in those patients. And if we don't want to fail in order to be effective, we should use this table, because if we are very effective in the evaluation stratification of the risk, if we know what is the goal of the therapy for those patients, and what is the expected reduction based on the baseline level of LDL cholesterol, we will always be very effective with those suggestions of the combination of those drugs, obviously included also inclisiran for very high and extremely high risk patients. And please have a look at our paper, because we have just published as a paper which emphasized the role of the upfront combination therapy and the use of fixed dose combination. In all those patients at the very high risk atherosclerotic cardiovascular disease, FH, and complete statin intolerance patients, inclisiran might add a lot as a part of the PCSK9 inhibition therapy, because altogether, if we combine 4 drugs, so high intensity statin therapy, fixed dose combination of bempedoic acid and ezetimibe, and PCSK9 inhibition, so targeted approach therapy, we might be even over 85% of the reduction of the LDL cholesterol, but we should always focus on each step very carefully, and we cannot miss each step of this therapy, each part of this upfront combination therapy, because then we will be not simply effective. And please have a look at my final slides associated with the very recent data. This is the data of the Orion 3 program presented at the American Heart Association Congress and the European Society of Cardiology Congress as well. And please have a look. It was a kind of maintained a reduction of the LDL cholesterol in the follow-up of even over 4 years. Altogether, it was about 47.5% reduction at the beginning of the Orion 3 program, and altogether it was 44.2% reduction with 8 injections of inclisiran. The question is obviously whether this reduction, which is maintained obviously and very typical for inclisiran, is suitable and enough for triple therapy for very high risk patients, especially those patients with FH with the very high baseline level of LDL cholesterol, when for PCSK9 inhibitors we may have even over 60% maintained reduction. So this is something that we probably need to look in the real world data. What is more, we have the first meta-analysis suggested that it will be this reduction, this adherence will be associated with a significant reduction of the cardiovascular outcomes, and this is the confirmation of the pooled analysis of the Orion 9 or Orion 11, when there is a suggestion that this reduction might be even 25%. In fact, we have the same data, as you remember, from the Odyssey long-term and Osler published in New England Journal of Medicine in NAME, and it was the same level of reduction. So I would be very happy if we have the level of reduction of 15 to 20% at the end of the Orion 4 program. And in fact, we need to wait for the Orion 4 and Orion and Victorian to prevent program in order to see the effect of inclisiran on the cardiovascular outcomes. And finally, please, as a comparison, please look at the beautiful data for alirocumab and velokumab concerning the long-term effects. So simply, it was presented at the ESC and American Heart Association congresses. You know it very well that simply for such a way of intensive treatment with triple therapy, with double therapy, simply with intensive lipid-lowering therapy, we might observe the effect. The lower, the better for longer. So there was a continuous reduction of the all-cause mortality. It was 22% reduction in comparison to 15 to 20% in the main study, and 17% of the reduction of MACEs, and it was the same in the Fourier-Ola study with even 23% reduction of the cardiovascular death. Thank you so much, and thank you once again for the invitation.